From the Medical University of South Carolina, this is Science Never Sleeps, a show that explores the science, the people, and the stories behind the scenes of biomedical research happening at MUSC. I'm your host, Gwen Bushy. This episode of Science Never Sleeps is about a challenging topic, but it's one that's important to discuss. In this episode, we'll be talking about how research is helping us understand treatments that can help children who are negatively impacted by trauma to lead healthy lives into adulthood. Child trauma definitely isn't easy to think about. Potentially traumatic events that children may experience can include psychological, physical, or sexual abuse, community or school violence, racism-related traumas, witnessing or experiencing domestic violence, the sudden or violent loss of a loved one, and military family-related stressors like deployment, parental loss, or injury. According to the Substance Abuse and Mental Health Services Administration, more than 2/3 of children report experiencing at least one traumatic event by the age of 16. Trauma affects us all differently, and the same is true for children. Understanding how we can prevent trauma and reduce the impact of trauma when it occurs is key to reducing other risky behaviors that can negatively impact children and adolescents into adulthood, like substance use and risky sexual behavior. Our guest in this episode is Dr. Carla Kmet-Danielson. Dr. Danielson is a clinical psychologist and professor at the National Crime Victims Research and Treatment Center within the Department of Psychiatry and Behavioral Sciences at the Medical University of South Carolina. Her areas of research and clinical expertise focus on understanding how trauma and stress can lead to mental health problems, particularly in adolescents, and how those exposures may lead to substance use problems and risky sexual behavior. Dr. Danielson is the director of the Empower program at MUSC, and she's also the developer of Risk Reduction Through Family Therapy, also called RRFT, an exposure-based integrative treatment for adolescents who experience both PTSD symptoms and substance use problems. She's currently leading a large-scale randomized controlled trial evaluation of RRFT funded by the National Institute on Drug Abuse. This episode does discuss traumatic childhood experiences, so please be sure to take care of yourself as you listen. Stay with us. Dr. Danielson, welcome to Science Never Sleeps.
Thank you so much for having me this morning.
I am really excited about our conversation in this episode because I think it's so important to talk about these issues. And I want to start out by really talking about the broad subject of trauma. I think it's one that certainly a lot of attention has been paid to over the last decade or so as we've learned about studies like the ACEs study and we try to learn more about trauma and how it affects us all, but particularly how it affects children is so important. So can you talk a little bit about trauma and how it may be different for children?
Absolutely. And I want to emphasize the introduction that you gave, I thought, did a really nice job of referring to trauma initially as potentially traumatic events. And I think we'll reduce that to trauma as we talk throughout today's podcast. But that word potentially is really important because we know, as you emphasize, that trauma affects everybody differently. And the great majority of people who experience a potentially traumatic event or trauma do not go on to develop mental health problems or experience problems because of that. Majority are resilient, so that's really, really good news. But there are cases where youth and adults go on to develop mental health problems following traumatic event experiences. And so those are, I think, most of the folks that we'll end up talking about today. In terms of among those kiddos who are impacted by trauma, I would say we see lots of different clinical presentations, meaning lots of different ways in which we see different types of mental health symptoms in the aftermath of a trauma. So, for example, we often talk about post-traumatic stress disorder or PTSD. And within PTSD, we are talking about hyperarousal. We're talking about re-experiencing or feeling like you're experiencing the trauma again. We're talking about what is a fancy way of saying negative alteration and cognition and feeling, but really having had experienced the trauma leading to hard feelings, negative thoughts, inaccurate, unhelpful thoughts about yourself, about the world, about others. And then perhaps the most common one, which is avoidance. So really not wanting to think about the trauma, talk about the trauma, have memories associated with the trauma. And so those are common things that we see in young people who experience trauma. However, there are also many other types of presentations or problems that we see sometimes after somebody has experienced a trauma. Those can include depression. Those can include substance use behaviors. Those can include other forms of anxiety. Those can include other types of risky behaviors too, such as running away, school refusal, and risky sexual behavior. And so really, there's, as you emphasized in your question, the kids are impacted in many different ways.
And I think the PTSD point is important because we think about PTSD often in adults, particularly when we're thinking about those who have completed military service and have experienced trauma within that. But really, it transcends age, and anyone can experience it, particularly children as well.
Correct. Absolutely. And with kiddos, we sometimes see more irritability, perhaps. We may see avoidance in other forms. I mentioned the school refusal as an example. But absolutely, we see that in young people as well.
And school refusal
is not wanting to go to school, or actually going all the way to not getting out of bed, not getting into the car, or not getting out of the car when you get to the school,
right?
Or perhaps not even making it to class while you're at the school.
Right. And are there certain things that we might see as adults who have children in our lives that we love, who we suspect may have experienced a trauma, that we might see? School refusal makes me think of that because certainly if you had a kid who was really excited to go to school,
that's right,
and suddenly decided that they didn't want to be there anymore, that might be a trigger to think something may need to be looked into there. Are there other things that adults can look at?
Yes, and that's really important. As you emphasized in your intro as well, unfortunately, experiencing potentially traumatic events is common. Majority of people, up to 70%, will experience that by the time they're 18 years old. And so we know, unfortunately, most kiddos will end up going through something like that. The question will be, are they impacted by it, right? So what should adults be looking at? And I would include in that adults beyond caregivers, teachers as well, because that is a window of opportunity. Our teachers are just so wonderful. They're spending so much time with our youth, and so it's a great opportunity to capture when something is going on that may not otherwise be observed. So I would say sleepiness, and again, I know these everything I'm going to say absolutely are not, complete. Yes, if you see this means this youth has experienced trauma. It's one of many symptoms, and these are also symptoms that could just be that the kid didn't get a good night's sleep that night. So let me emphasize that too. But we do know that nighttime can be a hard time if you're in a home where there's domestic violence going on, or if you're in a home in a bedroom where perhaps you experienced sexual abuse. It can lead to a really hard time going to sleep at night. And so then in turn, they get to school and they're very tired. So that's something to think about. Withdrawal, so not wanting to engage with peers. The other of particularly if you see that difference, right? If at one point they were and then they start to not do so. I would say generally not answering questions. And again, I have a 12-year-old son, and he doesn't always love to answer questions either. Right. But, if you're if maybe you're talking about family life at home, you're talking about other things, and you observe that a kid is having a hard time talking about that. And caregivers know their own children a lot. So same thing, if you notice a difference in how they had previously been, could be puberty, or could be that something has happened that's challenging for them to talk about. I would say if you suspect something's going on, you can always use a gentle intro into it, meaning maybe perhaps talk about something you read or something you saw in the news or something you heard about that is along the lines of something you suspect. And you can say, well, what are your thoughts about that? Asking open-ended questions like that instead of going directly after, did this happen? Did something happen at school? And that may be an easier way for them to see that you're comfortable talking with those topics. You would expect that they might have something to say about those topics and maybe make it a little bit easier for them to disclose to you. Mm-hmm. Unfortunately, most kids who experience trauma don't disclose when it happens. And if they do, it's often much later than when the incident happens. Right. And so, again, as a preventionist, my suggestion would be actually to have those discussions, not as waiting for when you see signs or symptoms that something may be wrong, but instead of it just being part of your household conversation. Right. Just like we emphasize about mental health and coping and substance use and sex, you want to have those conversations early on and on an ongoing basis so that in your household, your kiddo knows that those are safe topics, those are okay topics, and that you are letting them know if something were to ever happen, you would want them to share that with you.
Right. It's really establishing open lines of communication very early. My background is in sexual abuse prevention, and so we would talk about using proper names for body parts very early.
Correct.
Because that's what opens up those lines of communication and help your children be able to talk to you. So yeah, definitely having those open lines from a young age is essential.
And that can be hard. I mean, to me, that's been a surprising thing, is to see that it takes some time for caregivers sometimes to get comfortable having those conversations, and that's okay. So that's why we encourage you to practice saying the words out loud. If you didn't grow up saying penis and vagina, then you might take some time to practice doing that so that when you talk to your kid about it, you aren't turning red, you aren't stumbling over the words and teaching them that this is something embarrassing to be talking about.
Right. So we're going to talk more about treatment, and we're going to come back to that in a bit. But I want to really ask you sort of personally, and this is, Science Never Sleeps is an opportunity to talk about stories and how researchers, kind of came to where they are and got to study the things they're studying. And so as a clinical psychologist, I am really, I love the work that you're doing, but I have to ask, is this where you thought you would land? Is it sort of where you always wanted to go, or did you find a path that brought you here? Tell us a little bit about that story.
Yeah, absolutely. I'll start with the punchline, which is I absolutely believe that I am exactly where I'm supposed to be, and doing exactly what I'm supposed to be doing. And I'm exceptionally blessed to love what I do, which is really important. But no, I did not. When you are 18 and you're thinking about these things, this is not what I had initially predicted. I knew psychology was something I wanted to pursue. Theater was something I also was very interested in, but I was the first one in my family to go to college, and my parents said, well, you can act without a degree, but you can't do anything else. So without a degree. So why don't we explore a couple things? And so that was one of my great interests. And like many folks who go into psychology, it started with an interest in just talking to people and enjoying supporting people and listening to people. So, but I learned really quickly, as I mentioned, we didn't have a long family history of academics in our family. And honestly, I don't think I could point to a single woman doctor that I knew growing up. And so going to undergraduate, I was at Ohio University, was really my first intro to what different career pathways could look like that would blend. I did always enjoy my science classes, so kind of merge my interest in science, be able to pursue a doctoral degree without having to do a cadaver lab and work with things that involve blood and things like that. So that also felt like a really good fit, but would help me really get more into the depth beyond being able to help people one at a time, more get into the science behind helping people to understand how best to help people, why people develop mental health problems, and then how to intervene with that, just was a really, really exciting opportunity. So what I learned about that academic research pathway in undergrad, thanks to my honors thesis advisor, Dr. Arcus, that was really what started me down that path. But in my doctoral program at Case Western Reserve University, I was working with Dr. Eric Youngstrom, who is my wonderful, brilliant advisor in the area of bipolar disorder and unipolar depression in youth, and with a particular emphasis or interest, I will say, for my part, in high-risk adolescents. So as I spent time with high-risk adolescents and talking with them about their histories, one theme that kept coming up was trauma, that the great majority of them experienced trauma, and it was clearly a significant element as part of their history when they would talk about their depression or their bipolar symptoms. And so that led me to want to learn more about that. And so in clinical psychology, we do our 1-year residency before we get our doctoral degree. And so I was very fortunate to match here at MUSC, which is truly the best place in the country if you want to learn about how to treat traumatic stress symptoms, if you want to learn about research in this. Dr. Dean Kilpatrick, who is the director of the National Crime Victim Center, founded the we call it the NCVC, almost 50 years ago. I think we're in the 45-year anniversary coming up. And so he is really one of the forerunners in teaching people and learning how best to assess trauma, how to ask people about that. You can ask that, help train some of the leaders in treatment development, and so on. So anyway, fortunate enough to land here for my internship year. And my plan had been to learn about that and take it back to Cleveland. But that saying that life is what happens when you're busy making plans, right? And in my first month or so, one of my rotations at the CVC included going over to D. Norton Child Advocacy Center, where we would staff a lot of cases in the community of youth who had experienced abuse. And I can still remember sitting around that table, and it's a multidisciplinary effort, right? So you have child advocates, you have school representation, you have child protective services often, sometimes police, certainly mental health represented, and it was just a really incredible experience to see everybody coming together as a team to truly work together to help a child, a family. And there was a lot of passion. And I'm half Italian, but the Italian side is kind of forward for me. So it was a very good fit for my personality to see that passion and that advocacy going on. And it was really in that moment that I knew that this was my path. The kind of the science behind traumatic stress, but also very, very applied on the ground. And of course, the fact that we are in Charleston, South Carolina doesn't hurt either. The weather isn't too bad here. I do like the sunshine. So those things kind of came together. And really it was from there, while I was an intern, one of the things that we struggled a lot with at the CVC were the adolescents who presented less with PTSD forward and more with those risk behaviors. And some of the things that were said, which were very, very true, were, we implement evidence-based treatments here at the CVC, and we don't have an evidence-based treatment for co-occurring substance use and PTSD, for example. So we need to refer out, get the substance use piece addressed, and then come back for the trauma piece. And at the time, I just spent a lot of time reflecting on, but what if the trauma is a driving factor, right, for the substance use? And so that was really what was the birth of the next 15 years of my career, of one of the primary paths of my research, which has been focused on development and evaluation, and now at this point, implementation of an evidence-based treatment for co-occurring substance use and PTSD in youth.
Right. And so that's where I want to go next, but before we go there, I want to ask about your lab. Mm-hmm. So you landed at MUSC, you did your preliminary work, you got to the point where you have your own lab now, and it's called the Invictus Lab. Yes. Tell us about your lab.
Yes. So Invictus, if folks are familiar with Henley's poem, Invictus. It was my father's favorite poem, and so it was one I was very familiar with. And one of the things that, as I mentioned, that there's a lot of kids who are resilient after trauma, and a lot of young people who are resilient, but there are youth who still need to learn that they have the capacity to be resilient and how to be resilient. And in the Invictus poem, the last two lines focus on, I am the master of my fate, I am the captain of my soul. It begins with, out of the darkness I rise, and then kind of comes back to this very positive, inspirational component. And I really feel like that is what everything in the lab that we do is about. That is about how do we help young people learn to best become the master of their fate and the captain of their soul. And we can do that through prevention. We can do that by, how do we do prevention? Well, we need to better understand what are the targets for prevention after somebody experiences a trauma. We can do that through treatment, and we can do that through really bringing services to other people. And so all of that is part of our work. So just how do we bend those trajectories in positive ways to do so?
So we talked about trauma. Let's talk for a second about resilience, because that's sort of the antidote to some degree to trauma.
Right.
Talk a little bit about resilience. What is that? How do we gain it? Where does it come from, particularly in the lives of children?
Yes, and I like that question a lot, because I think that that's a really important emphasis. Every child, every family, every caregiver has strengths. And what those are look different. And so I would argue there's not one definition for resiliency for any particular family, right? But it's, can we find the strengths and capitalize on the strengths so that people are able to accomplish their everyday tasks. So we talk about functioning a lot. How does a mental health problem or mental health symptoms impact daily functioning? Are you able to go to school and learn and have friendships and have enjoy your family relationships? Are you able to, if you have interests and hobbies in any given area, are you able to engage in that and celebrate that? I'm also, like to think about people looking forward, right? Forward is a pace. And so even if somebody, for one person, resiliency might be, I want to go all the way and become a psychologist myself and help people. Well, for some people, that resiliency might be finishing high school, right?
When you were discussing earlier working with the National Crime Victims Research and Treatment Center here at MUSC, you made a point to mention that the treatments that are used at MUSC are evidence-based. And tell us a little bit about that. And then I'd like you to talk about the evidence-based treatments that you have been working on as a researcher and understanding how they work.
Wonderful question. I'm so glad you asked. Just like we test medications, right, to figure out if something is going to work and help treat a problem through randomized controlled trials, clinical trials, where we compare one medication to another medication and we figure out which one works better for a given problem. We do the same thing with therapy, with talking therapy. And that's really important because we want people to be able to maximize their resources when they meet with a clinician, that they are using that time to engage in a treatment that we know that works. And so I really like to emphasize that point for consumers out there. Just know that when you are seeking mental health services for yourself or for your youth, it's important to ask what treatments a clinician is skilled in and applies, because you want to make sure that they offer the treatment that would be helpful for your particular problem. In this case, trauma. So in evidence-based treatment, or also called empirically supported treatment, is a treatment that has undergone that rigorous evaluation of a randomized control trial in RCT and has been compared to at least one other treatment and has been shown to work better than if you did the other treatment. And so the treatment, as I mentioned, at the National Crime Victim Center as an intern, that at that time that we didn't have that, an evidence-based treatment for co-occurring, for adolescents with co-occurring PTSD symptoms and substance use. And so that was really the opportunity to figure out what did we need to do to develop that. And the really good news was at that time, though, we did, and still today, have evidence-based treatments for PTSD symptoms in youth. Trauma-focused cognitive behavioral therapy, TFCBT, is one of our most evidence-based treatments for PTSD. For really any child mental health problem. There were well over 20 randomized controlled trials at this point evaluating and showing that TFCBT works. And so, and then in parallel, we have evidence-based treatments for adolescent substance use problems. And in fact, one of them, multisystemic therapy, also came from a lot of work led by Scott Hengler here some years ago. And so what my thought was, we don't need to reinvent the wheel. Why don't we integrate these treatments that have these interventions that we know work or are based on principles that we know work? And really, that's what I did. I was very fortunate to be able to work with the developers of TFCBT and the developer of MST, as well as others who worked with re-victimization prevention, who worked with risky sexual behavior, and really just came up with a structured strategy within a treatment for clinicians to be able to address these multiple problems that we see after an adolescent experiences trauma. RFT has 7 components: psychoeducation and engagement, family communication, coping, substance use, PTSD, and re-victimization risk reduction. However, for example, during the pilot trial, we did not have family communication as its own component. However, that was part of the feedback from the clinicians, and from doing my own work. I also served as a clinician as I was developing this treatment to really, that's the best way to figure out what works and what doesn't, right? And so then the next step was a small pilot randomized control trial funded through NIDA, a K award I was very fortunate to receive, and then onto what turned out to be my first R01. And R01 is a large research grant that is focused on science. That is a pretty sure thing is a strong language, but in order for NIH to give you an R01, they need to feel pretty good that you're going to do the science well and that it's going to work out.
Right.
So that was also done here at MUSC, and so that is what led to actually the publication in JAMA Psychiatry, where we were able to share results with the world that RFT, risk reduction through family therapy, does in fact work, is efficacious in reducing substance use problems and PTSD for adolescents with these co-occurring problems. And so that was very, very exciting. And now we have another R01. We're working with a team at the University of Colorado, Denver, with my co-principal investigator, Dr. Paula Riggs, who's a child and adolescent psychiatrist, in implementing RFT in Denver, which adds another interesting element is that marijuana is legalized in Colorado, and not for youth. However, data suggests that areas that have legalized marijuana, that impacts things in terms of rates and severity. And so we're very excited to see how that turns out.
So the RFT really is about leveraging the family unit. It is family therapy. So it's about empowering, supporting the family unit to sort of build that resilience.
Yes. However, I would probably, if I could go back in time and name it something a little bit broader than that, I would, because really we focus on the child's ecologies and family. So ecologies are the systems, right? We don't exist as individuals in a vacuum. So we have the individual layer, and this comes from Bronfenbrenner, by the way. So this is for those of you listening who are Bronfenbrenner fans, this will sound very familiar. So we have an individual layer, and then a family layer outside of that, and then we have a peer layer outside of that, and then we have a school layer outside of that, and then we have a community layer outside of that. And really, what RFT does is focuses on, for that particular kid, for that particular family, what are the specific risk and protective factors for substance use, for PTSD. And we focus on reducing the risk factors and promoting the protective factors. So family can look very different. I mean, we can do RFT. Of course, our goal is to have a youth who has a caregiver for us to work with, but sometimes that caregiver is a staff member at a group home. Sometimes that caregiver is a foster parent. Sometimes that caregiver is not somebody that we ever get to work with directly, but we work with the youth on family communication skills, such that many of these youth, even if they are in families from whom they're separated, whom aren't able to take care of them, many of them end up deciding at 18 to go back into those families or still have communication with the families, which is also understandable. And so how do we help build their resiliency and be able to cope with having these relationships with people that have complicating factors?
Right. And giving them the skills that they need to be able to navigate those spaces.
Correct. But again, when oftentimes we're fortunate to be able to work with some caregiver, and in those circumstances, we really work with empowering the caregiver that they have the capacity to return to whatever treatment goals they have. Oftentimes it's about repairing the relationship with the youth, helping the youth have a healthy future. Many of these caregivers have their own trauma history. Many of these caregivers are at their end of their rope, very understandably, because they have had a lot of trials and tribulations to get to this point where they're a teen, right? And so part of our work in RFT is building their parenting efficacy again, that they have the capacity to do this, and that it isn't that they are part of the problem, it's that they're the most critical part of the solution.
Right.
In substance use, and this is true for adolescents or adults, we unfortunately have a lot of high relapse rates. While treatment's in place, people do well. When treatments are removed, we tend to see symptoms return.
Right.
And short of treatment being a lifelong process, which is really hard for that to be the case, what our goal in RFT then, and this really comes from the MST principles, is that generalization, that long-term sustainability of the skills. And so as much as as dedicated as our RFT clinicians are, most of them are unlikely to adopt these kids and bring them home with them. So in lieu of that, lieu of them being able to be in their lives forever, who will be in their lives forever, who can be the ones to help sustain the gains that they have made, and work with them on making good choices when it comes to being in parties and being around marijuana and other forms of substances and pills and whatnot.
Right. I was first introduced to you and your work as I was learning more about the CHARM study, which is another great study around understanding how best to serve children and their families. Tell us about CHARM.
Very excited to be able to talk with you about the CHARM study, which stands for the Charleston Resiliency Monitoring Study. That is something that I want to say out of the gates has been a great team effort, as most of my research has been. I think that if that's okay for me to interject that here.
Of course.
That the study of trauma is very much a team science. It requires a team science, which means everybody from experts from different fields to our staff members, our research assistants, our project coordinators, everybody is such a critical part of this team. So everything that I'm talking about today is truly the result of teamwork. And I wish that I could give a shout out to every single person who has been on my team and all of my collaborators, but we would be here all day because that is how fortunate I have been. That is how many wonderful experts we have here at MUSC and beyond. We know that when somebody experiences a potentially traumatic event, that not everybody goes on to develop mental health problems, right? But some do. What we don't know in fine-grained detail is exactly why that is, right? What are the mechanisms? What are the pathways that promote resiliency after an event has been experienced versus people going on to develop anxiety disorders, depression, substance use. And so really, CHARM is about helping us better understand that pathway from child maltreatment in particular, but other forms of trauma as well, onto anxiety disorders and other forms of mental health problems, with a particular mechanism that we have focused on, which the fancy word is threat-related negative valence systems, but that is a fancy way of saying, how do we process threat? So we are trying to understand that if after somebody has experienced traumatic events, somebody has experienced child maltreatment, how does that impact their threat processing? And then in turn, does that altered threat processing potentially lead to these outcomes that we talked about, these mental health outcomes? How we go about doing that, or how we've gone about studying that, is multifaceted. This is something that our funder for this study, the National Institute of Mental Health, NIMH, has really put forward this matrix, this conceptualization of how to best approach research questions within mental health. It's called RDoC system, the Research Domain Criteria. So this is an RDoC study. So that means when we're studying this pathway of threat processing, we're doing it in many different ways. We're doing it through neuroimaging. We're doing it through psychophysiology, so EEG, startle. We're looking at blinks, for example, in the face of a stressor. And we're looking at cortisol reactivity. Of course, we're doing clinical interviewing that has to do with trauma history, that has to do with mental health symptoms, and so on. And so what that means is that very, very, very proud of and grateful for the youth and the families who have participated in this study, because those lab visits could be up to 8 hours at a time when they came in. So, and importantly, for us to understand these questions best, we need to look at these things over time. So this is what we call a longitudinal study. So at baseline, meaning the first time that we assessed these kids, they were in 3rd, 6th, and 9th grade. We were very fortunate to recruit 364 youth and their caregivers to participate. And then we followed them up 2 different times after that in person, as well as intermediate phone calls to check in regarding trauma history and new onset of mental health symptoms. And so in those in-person visits, we would bring them into the scanner and subject them to tasks that had to do with attention to different types of pictures. Some that might elicit positive emotion, some that might elicit negative emotion, some more neutral. Same thing true with our psychophysiology tasks. And we were looking at things like, how does the brain respond when you make a mistake, which has been argued that that's a form of a threat when you make a mistake, as well as how does somebody respond. That's the startle piece, when you are presented with things that you may not expect, as well as when things startling images that you may expect, and so on. So it's a lot of data, as I mentioned. So this is 3 in-person visits over a 2-year period, as well as those 2 intermediate phone calls. And we are just now at the stage. I'm very thrilled to say we are done with data collection, but as you can imagine, during the pandemic, this was going on, and so there were some challenges there. But also with our challenges come silver linings, and so one of the unique things we're really going to be able to talk about is impact of pandemic as a potential significant stressor as well for these families. So we did assess how pandemic affected their lives over the past 2 years as well. And so we'll have an opportunity to also see how that may or may not have impacted things in this relation between trauma, child maltreatment, and mental health problems.
That's really great, because I do think we're on the front end of what is the research going to yield around the pandemic and the impact that it had in lots of different ways. I mean, we can make a list of all of the ways that humans were impacted by the pandemic, but I think particularly children is really an important question to answer, to kind of understand how did all kinds of things, whether it was the perceived health threat of that scary thing, or losing loved ones, or being separated from their peers for such a long period. So that's really great, because that's research that's yet to be really out there.
And one thing that we do know well in the child trauma research arena is that impact of trauma is cumulative. And so as you experience more trauma, more adversities, you're more likely to develop mental health problems following. And so I think the pandemic stressor is something that we hypothesize will end up being something that added accumulation potentially to impact. And anecdotally, we heard that when we were interviewing our families and talking to families during the height of the pandemic. A lot of folks would mention things like, I never thought about, or it's been a long time since I've thought about this trauma. It didn't really impact me. But now that we're going through the stressors of the pandemic in their own language, I'm thinking about it all the time, and I don't understand why. Why is it bothering me now? It didn't bother me before. And that's very normal. So it heightened their sensitivity to stressors that had happened previously. So I think we do have an opportunity to learn a lot of that. We do know that a national state of emergency has been declared for child mental health across the country. That was jointly declared by the American Academy of Pediatrics, the Child and Adolescent, American Academy of Child and Adolescent Psychiatry, and the American Hospital Association. So it's clear enough that there has been an impact that was declared in October of 2021. We definitely see published reports of increased opiate overdoses. We see, again, this is anecdotally, clinicians and even our own clinic on wait lists that we've never seen, at least in the 20 years that I've been here. I've never seen our wait list at the level it is right now, but just to keep up with the number of referrals that come in. And I know all of our community clinicians are in similar positions. So, and all of us are just incredibly dedicated to ensure that everybody who needs service gets service. So we work a lot with our community partners, the schools, child advocacy centers, to make sure that, if we can't get to a kid immediately, that we'll figure out where we can connect them with services.
Right. We do focus on research on Science Never Sleeps, but I think you just talked about service, and I think that's important because particularly in the space that you're in, it really is about translational research where it's moving towards how do we provide this service that ultimately improves the lives of children, their families, and we can also talk about the downstream, generational positive impacts that this kind of thing can have. So I want to ask about Empower, which really is more of an extension of the research. It's services that have been derived from what we've learned through research. So can you talk a little bit about Empower?
Yes. I really enjoy talking about Empower because, as I mentioned earlier, I'm a preventionist at heart. And I think at the end of the day, of course, our goal is to ultimately prevent mental health problems after folks experience traumatic event experience, as well as other general life stressors, if we can. Unfortunately, many youth do not line up for prevention services. And so we have to be creative in how we think about bringing prevention to the community. Empower actually came from a call from SAMHSA in 2007. And I remember that because I remember my daughter being about 9 months old when I was pulling my all-nighters to write this grant. to be able to bring prevention, HIV and substance use prevention services to our community. So it wasn't specific to trauma per se, but given those base rates I talked about trauma, there's certainly a lot of overlap there. But I had learned, I didn't know this, and I think many people don't know this, that our HIV acquisition rates here in South Carolina, including in the Charleston surrounding area, are quite high. With regard compared to national rates. South Carolina has been in the top 10 for many years with regard to new HIV acquisition rates. And so it was very important to think about how might we parlay this into our opportunity that we have in working in our community, working with schools, working with the Department of Juvenile Justice, for example. And so that was that first grant that we were fortunate to get funded to implement these prevention services in the community. Since then, we have been fortunate to receive a range of grants building on that program and form even more community partnerships. Palmetto Community Care, our infectious diseases department here at MUSC, Roper, many partners in the community. And so we have worked to also expand to local colleges. Dr. Alyssa Reingold, who's one of my colleagues, has helped lead that work with young adults. We do, for example, community testing, HIV testing events for that. And most recently, SAMHSA has multiple branches, prevention branch, but also offer a treatment branch. And I mentioned earlier the Family Tree Grant. And so here at MUSC, we were fortunate to be one of only 18 places across the country who were awarded this grant. And Family Tree, as it implies, is that we're focusing not just on, in this particular case, adolescents with substance use problems, but also the branches of that tree, which include caregivers, right, and other community aspects. And so we were fortunate to receive that actually provides funding for RFT clinicians and clinicians who are implementing evidence-based treatments for substance use disorders, but do not have the co-occurring traumatic stress piece. And that's housed in our Center for Drug and Alcohol Programs, our CDAP program, who are very much a partner on this. And so we're very fortunate to have those resources in place now to be able to implement those services. Those we have just launched within the past about 6 months, maybe, and we are already close to wait list / on wait list for those clinicians. So as we suspected, there's a huge demand for this. And so we're very grateful for any opportunity to have these resources to be able to fund us to do this. As I mentioned before, the Glenn Family Foundation also has been an opportunity for us to be able to provide some of these services in the community that otherwise would not be possible without those funds. Along those lines, we have a long road ahead of us. We are so excited about the gains we have been able to make in the science and in the services. So we are grateful for the generous contributions, whether that be from the NIH, from other foundation funding, SAMHSA, on through private donors. And so if anyone is listening and are wondering, what is it that I can really do to make a difference with my resources, we are always open and looking for resources to be able to further what we can do with our these research questions that we have and with the services we like to provide, and can contact me.
Because at the end of the day, it's about improving the lives of children, which ultimately help us all as adults live happier, healthier lives.
100%. I can't emphasize that point enough. These youth grow up to be adults. They grow up to be contributing members of our society, or would like to be contributing members of our society. What PTSD and substance use disorder and other forms of mental health look like in adults is that much more impairing, right? It's that much more difficult to do those daily functioning tasks I was talking about earlier. It's not attending school. It's getting to work. It's paying your bills. It's being able to become parents and be able to sometimes stop intergenerational transmission of trauma that we see. And so it's just such a great opportunity when we have the ability to intervene earlier in life rather than waiting for these things to come up as adults. And we could get into the numbers. It is in the billions and billions of dollars, the degree to which it is estimated that the United States is impacted by substance use disorder and mental health problems. And so any prevention that we engage in, any financial contributions that we receive certainly play out tenfold in the long run for society.
Right. Thank you so much for being with us on Science Never Sleeps, Dr. Danielson.
Thank you so much, Gwen. I can't tell you how much I appreciate the opportunity to talk about the science, to talk about the work that we have done. My team and I are very grateful for you to be able to bring the message out to the public, because it doesn't do anybody any good sitting in journals, sitting in our conference rooms where we talk about these things. So we are working hard to get we are working hard to really think about how to get this to the very people who we're hoping to serve. So thank you so much for being a vehicle for that.
We've been talking to Dr. Carla Kimmett Danielson about her research on supporting children and adolescents who've experienced trauma. Have an idea for a future episode of Science Never Sleeps? Click on the link in our show notes to share with us. Science Never Sleeps is produced by the Office of the Vice President for Research at the Medical University of South Carolina. Special thanks to the Office of Instructional Technology for support on this episode.